Hi guys. So I'm going to be taking you through transfusions and blood products. This isn't really that high yield a topic, so don't worry if it's all new or you haven't heard any of it before. But I'll just take you through some of the more high yield points, and I've got like as much information as you could possibly need to know on these slides. So hopefully it helps. So just to start, this helps, or this slide is supposed to help you know what type of blood products to use. So if you have a problem with your coagulation, so that's a factor deficiency, or you're using warfarin or something, you're going to get deep hemarthrosis, so bleeding into your joints and bleeding into deeper spaces. Whereas if you just have a low platelet count, you're going to get petechiae, mucosal bleeding, and prolonged bleedings from small cuts. So they present slightly differently. So just talking about blood collection, weirdly, there was a question once about what medications are, what infections are screened for in blood. It's not EBV, but that was just one question a few years ago that was a bit dog. And you should know the parts of your blood. So you've got your plasma, your buffy coat, and your erythrocytes, which should be 45%. So your blood products, you've got your fresh flows and plasma. That's what we commonly see in a hospital. You can have subsections of fresh frozen plasma. For example, your cryoprecipitate has factor 8, 13, and von Willebrand factor. But mainly fresh frozen plasma is used, and you can store that for a year. So it's quite a long shelf life. Additionally, you can use some IV clotting factors and vitamin K. That's more for warfarin reversal. Platelets. This one's important. They've asked a few questions on this before. You can't freeze platelets, and they store them at room temperature. So you've got quite a high risk for bacterial seeding with platelets relative to the other blood products. And then you've got your packed red blood cells, which is kind of what we more think of as a blood transfusion, and that lasts for 42 days. So this is just a note in case you see irradiation and leukodepletion in your notes. So all platelet products are irradiated, but the other products aren't. And what this does is it, I guess, decreases the shelf life of the product, which is why we don't usually irradiate everything else. But it will protect your immunosuppressed host and reduce the activities of the white blood cells in them. Also, leukodepletion will reduce the risk of complications, and it just decreases the number of the white blood cells in the transfusion, and as such also decreases the risk of CMV, cytomegaloviral infection. So blood group types, I remember they did a really long, they did like a long workshop on this. It's pretty simple. So your A and B are codominant. You can have your 4 blood types. It's just important to know that your group O is your universal red cell donor, and group AB is the universal plasma donor. And that's because group AB doesn't have any antibodies to any anti-A or anti-B antibodies in the plasma. So that one's a bit good to know. Also, if you're blood type AB, you're also the universal recipient for blood, so you can take anyone's blood. The most common blood type is O positive, and I think the least common blood type is AB negative. And this is important to know, when you are born, like as soon as you're born, you will start developing antibodies, which are IgM, to the blood type that you're not. So if you're like blood type A, as soon as you're born, you're going to be developing anti-B antibodies, and that's in your blood. But these are IgM and they can't cross the placenta. So they don't usually cause a hemolytic disease of the newborn, unless in like some very rare cases. So rhesus factor is important. It's we mainly look at rhesus factor D because that's the most common in our population, and you can be rhesus factor D positive or rhesus factor D negative. Now, important to know, unlike the other, the like main blood types, you need an exposure to start developing rhesus factor antibodies. And the antibodies you develop are IgG, which can cross the placenta. So essentially, if you have a rhesus factor negative mother, she needs to have an exposure to develop those antibodies. And that exposure can happen when she's giving birth to her first child. And the child is obviously going to have to be rhesus factor positive, or it can actually happen through blood products if she's been exposed to positive or like a positive blood product in the past, which has rhesus factor D positive in it. So she needs that exposure event. And then the subsequent pregnancy is going to be complicated by the fact that the mother's IgG antibodies to rhesus factor can now cross the placenta and attack the child if the child has a positive rhesus factor. And that causes your hemolytic disease of the newborn. So yeah, here, prevention, give anti-D immunoglobulin during sensitizing events, so during birth, or transfuse O negative in all young women. Otherwise, you can, like if it's a guy, you could just give them O positive, but in young women who are of childbearing or pre-childbearing age, give them O negative. These are just some complications of transfusions. You don't really have to know them too well, but I have them quite specifically listed here. Probably the only one you need to know is your acute hemolytic transfusion reaction. This is when someone's been given the wrong blood product, which is something you want to avoid. And you'll get like a pretty immediate reaction, feverish, renal failure. They get very sick very quickly. But sometimes after giving blood, because they're like you have to monitor very carefully after you've given a blood transfusion, people can just get a transient fever, and that's not as worrying. You can also get allergic reactions. That's a lot rarer, to be honest. Bacterial transmission, which, as I mentioned, is got a risk with platelets mainly, or you can get transfusion-related lung injury. Look, maybe just know that it exists. I don't really think you need to understand the whole HLA plasma thing at all. These are just some longer term infections. Graft versus host disease is when the white blood cells in the transfusion attack an immunocompromised host. And with your delayed hemolytic transfusion reactions, this isn't your ABO incompatibility. It's another kind of antibody, maybe a rarer antibody that they haven't screened for. And it gives you a bit more of a chronic picture. People don't tend to get quite as sick with that as well, as a rule. And then finally, I think I just put this in here because everyone seems to get confused about Coombs tests. So you've got your direct and your indirect. Your direct is what you're doing when you think someone is having an autoimmune hemolytic anemia. So it detects antibodies that are stuck to someone's red blood cells. So yeah, you're doing that to screen if you're concerned someone's had an autoimmune hemolytic anemic reaction. You're doing that immediately afterwards. You can do it in hemolytic disease of the newborn as well, transfusion reactions as well. Whereas your indirect Coombs test is looking for antibodies in the plasma. And as such, it's usually done in pre-transfusion testing. So when you're working out what blood type someone is. And then I've finally just put in a section here about a hemolysis screen. Again, it might just be helpful for answering some MCQs. If it's an autoimmune hemolytic anemia, so there's antibodies that are causing the destruction, you're going to be a direct Coombs test positive. However, in any other hemolysis, like any other hemolytic anemias really, you'll get a high LDH, a decreased haptoglobin, and an increased unconjugated bilirubin. Awesome. And if you have any questions, feel free to send an email. My email's on the slides.